All right, thank you. This is a case of a recurrent myocarditis that was unraveled as an arrhythmogenic cardiomyopathy. And for those who don't know me, again, my name is Ryan. I'm one of the second-year cardiology residents. I have no disclosures, and consent was obtained to discuss this case. So to briefly discuss the learning objectives for today, we're going to highlight a case of recurrent myocarditis. We'll discuss some etiologies of arrhythmogenic cardiomyopathies. We'll review echo imaging of the RV, and then talk a little bit about features and characteristics of Desmoplakin cardiomyopathy and exercise restrictions in cardiomyopathies. So without further ado, we'll start with the case. So a 23-year-old female who is having recurrent chest pain presented in the community hospital. She had been having ongoing episodes of chest pain and dyspnea, and she had been diagnosed with myocarditis. She had had several episodes of this. Every time she presented to the hospital, she had an elevated troponin. She had some ECG changes, primarily some ST changes and T-wave inversions in the anterolateral leads. And she went on to have a cardiac MRI that showed some late gadolinium enhancement in a mildly dilated ventricle. So with these findings, it seemed pretty consistent with the diagnosis of myocarditis, maybe some myopericarditis. And so she was started on bisoprolol and colchicine for treatment of that. She had no past medical history. She wasn't on any medications. She had no family history. And importantly, she was a competitive athlete in the university playing varsity level sports. So she did do quite a lot of exercise. So she'd been doing decently well for several years. She had a couple of recurrent episodes, and she was relatively asymptomatic, tolerating medications pretty well, continued to be involved in high-level sport, but she was sent to St. Mike's for review because she was still having ongoing episodes. She had a repeat cardiac MRI to reassess the left ventricle, and it revealed pretty much the same findings. So again, she came back. This was her ECG when she came back to St. Mike's. So for a mid-20-year-old, not the most normal of ECGs. It's normal sinus rhythm, normal access. There's some abnormal T waves in the anterolateral leads, specifically T-wave inversions in V1 through V4, maybe a little bit in V5 there as well, and some flattening in V6. And this is her echo that she had here at St. Mike's in 2019. So again, borderline kind of dilated ventricle, maybe low normal systolic function, somewhere 50–55%. Maybe on the parasternal long on the left there, you can appreciate maybe the RVOT is a little bit dilated there as well, but not a totally normal heart, but for someone who's in their 20s, probably more abnormal than we'd expect. And so that was reported as borderline dilated, linear dimensions of 48 millimeters, mildly reduced EF at around 50%, normal diastolic function, borderline dilated RV, and a dilated left atrium. So then she went on to have a repeat cardiac MRI, and that was relatively unchanged, showed that her EF was now 48% from 50%. Her RV was dilated, EF was 41%. She had some late gadolinium enhancement in the left ventricle, but negative T1 and T2 mapping, which would be evidence of myocardial edema. So there was no edema there, just some fibrosis. And the plan was still to just continue bisoprolol because the thought was still that she was just having episodes of myopericarditis. Then over several years, she continued to have recurrent symptoms. She started to develop some more non-specific chest symptoms in addition, primarily was dyspnea. She wasn't really having too many more episodes of her chest pain syndrome. So a chest x-ray was ordered. That was unremarkable. And then given that she was having recurrent episodes of this myocarditis type picture with chest pain and an elevated troponin, there was a question of whether or not she had sarcoidosis because of the kind of recurrent episodes of this inflammatory syndrome. So she went on to have a CT chest, which didn't show any evidence of lymphadenopathy, and then a PET scan, which was also negative for sarcoid. So nothing suggestive of that. Then on a routine follow-up, she ended up having recurrent PVCs on her ECG, which was a relatively new finding for her, but she went on to have a Holter monitor. Now, amongst all this, she continued to be quite active. She was still running over 5 kilometers several times a week. She still had good heart rate response to exercise, with her peak heart rates up into the 150s while she was exercising. But now her Holter monitor showed a PVC burden of 18%. So this is the first kind of time that we isolated significant amounts of PVCs. And then there was a question of, okay, is this maybe all PVC-induced cardiomyopathy causing her LV dysfunction? Only borderline reduced, but she has such a significant burden of PVCs. So she was sent to EP for adjustment of medications and see if we could kind of control these PVCs. She was quoted about a 1% year risk of sudden cardiac death, and they initially tried to just treat these PVCs medically. So her bisoprolol was increased, she had a repeat Holter monitor, and her PVC burden reduced a little bit to 13. Subsequently, it reduced a little bit further than that as well. So then in 2024, she came back. And in 2024, this was her echo. So in comparison to the one before, LV function's definitely down even more. LV is quite dilated. By volume, it's around 99 milliliters per meter squared. Now she has kind of moderately reduced LV function, and maybe a bit of some kind of hypokinesis in the basal to mid infra septum, which is also thinned. A couple more views of her echo here. So parasternal long and the two chamber with contrast. Again, can appreciate moderately reduced LV function. On the parasternal long, her RVOT is probably a little bit dilated there as well. And then looking at a focus view of her RV, RV is dilated, maybe mildly reduced RV systolic function. Also look like maybe a bit of hypokinesis up at the apex there. So her echo was reported as a dilated LV by volume, moderately reduced systolic function with an EF calculated by symptoms of 39%, moderate global hypokinesis with regional variability, some hypokinetic to akinetic segments in the basal to mid infra septum, and a dilated RV with mildly reduced systolic function. But now in 2024, she had yet another MRI. This is her MRI, and just to kind of show you briefly here, looks like all the kind of white or light stuff is evidence of the late gadolinium enhancement. So there's a bit of uptake in the pericardium up here, down in kind of the free wall of the RV.
The mouse doesn't synchronize to your laptop. Just have to look at the screen when you're pointing.
Okay. And then in the LV, we can see through here, basically all the way around.
I'll show you after.
Yeah, it's okay. So kind of some enhancement in the mid-myocardium, but the endocardium, which is all still black here, is not really affected. So that MRI was reported as stable biventricular dilation, mildly reduced systolic dysfunction. EF on that was 46, so there's been a slow decline over her 3 MRIs from low 50s to 48 to 46. Slight drop in her RVF at 39%. And the new finding on this MRI was that there was a new dyskinesia in the RVOT. So overall, the pattern of late gadolinium enhancement remained the same. It involved both ventricles. And so on this MRI, it was reported that the differential could be, again, myocarditis, sarcoidosis, or maybe biventricular ARVC or ARVD, which is one of the arrhythmogenic cardiomyopathies. So at this point, she was referred on to the Advanced Heart Failure and Transplant Clinic at TGH, and she was sent for genetic testing. A pan-cardiomyopathy panel was sent, and her gene for DSP or Desmoplakin cardiomyopathy came back positive. So we'll very quickly talk about kind of what DSP cardiomyopathy is. We'll talk about some of the arrhythmogenic cardiomyopathies, and then we'll go into some kind of key echo features that we can look for when investigating for the arrhythmogenic cardiomyopathies. So the Desmoplakin mutations cause a unique cardiomyopathy to have a higher prevalence for the LV compared to some of the other arrhythmogenic cardiomyopathies. They cause fibrosis and systolic dysfunction. They have similar kind of underlying molecular basis is the plakophilin 2, which is the gene that's associated with most of the right-sided arrhythmogenic cardiomyopathies. But the risk stratification criteria that we have previously had for ARVC is limited in its accuracy for diagnosing the Desmoplakin version, or the one that's more prominent on the left ventricle. And typically the way the disease process goes is you have episodic myocardial injury that contributes to progressive fibrosis, which precedes the development of LV dysfunction. So this is opposite of most cardiomyopathies, where you get LV dysfunction and you subsequently get LV fibrosis. So some of the clinical implications of the Desmoplakin cardiomyopathy are that clinical diagnosis relies on the assessment of LV function, arrhythmias, gadolinium enhancement, and genetics. It's something that we should always really consider on our differential diagnosis for myocardial inflammatory syndromes. So anyone that's having episodes of myocarditis, or especially recurring episodes of myocarditis, or sarcoidosis, where they have these kind of recurrent episodes of what seems like some sort of inflammation, so positive enzymes, symptoms, etc. And once they start to develop an EF less than 55%, this indicates pretty significant risk for severe ventricular arrhythmias and sudden cardiac death. So there's several criteria that have been published in the past for these arrhythmogenic cardiomyopathies. And in 2020, they released a new criteria called the Padua criteria, that is more specific and allows us to actually incorporate some of these left-sided cardiomyopathies as well. So going through the criteria here. So the first step is looking if there's any major or minor morphological and structural RV criteria that are met to determine if the right ventricle is affected. So looking at the criteria for the RV standpoint, so by 2D echo or by cardiac MRI, regional RV akinesia, dyskinesia, or bulging, plus one of RV dilation or decreased RV systolic function. So if we remember, her MRI showed dyskinesia of the RV outflow tract, so she meets that, and she had a mildly dilated RV with reduced RV systolic function. So there's a major criteria here for RV involvement. So we can proceed our way down the flow chart. Next, we're looking to see if they meet any LV criteria. So again, by 2D echo or by cardiac MRI, is there evidence of global LV systolic dysfunction, so reduced LVEF, with or without LV dilation? And again, her EF was 39%, and she had a moderately dilated LV. So we meet a major criteria for LV involvement. So next step is to determine, based on non-morphologic criteria, things like ECG, genetics, family history, does she have other major or minor criteria that would put her into a possible, borderline, or definite biventricular cardiomyopathy, or arrhythmogenic cardiomyopathy state. So looking at some of the other criteria here, so structural myocardial abnormalities at the top, is there transmural late gadolinium enhancement? So yes, we noted that on cardiac MRI. There's also late gadolinium enhancement in the LV, so we have a major criteria met at least for one of the two ventricles here. Looking at the ECG, there's inverted T waves in lead V1 and V2 in the absence of a complete right bundle branch block. So if we remember her ECG here, did have that, T-wave inversions in the anterolateral leads. And then ventricular arrhythmias, so frequent extrasystolic beats or PVCs greater than 500 per 24 hours. And so if you take someone with a heart rate of 60 beats per minute, that's roughly 0.5% PVC burden. So again, her PVC burden was upwards of 18%. She also had multifocal PVCs of both a right bundle and left bundle morphology, so she'd need both right and left-sided here. And then, of course, genetics, she did have a genetic mutation consistent with an ARVT in the Desmoplakin mutation. So again, she definitely meets criteria as definite biventricular cardiomyopathy. So moving forward, we'll do a little bit of time talking about echo. At this stage, I've talked a whole lot about kind of Desmoplakin cardiomyopathy, what it is, when it should be considered from the standpoint of recurrent episodes of inflammatory symptoms. And you may be saying to me, well, we see patients in the echo lab all the time that have LV dysfunction and wall motion abnormalities, and this is a relatively rare diagnosis, so surely we can't always be considering it for every patient that comes through the lab. And that's true. And partially the problem with using echo for the assessment of the left-sided version of the arrhythmogenic cardiomyopathies is that we often don't see any significant changes until we're relatively late on into the disease process. So we might note reduced LV function or reduced GLS, which kind of this we talked about in this patient, again, relatively far into the disease process. And we're looking for dilation and regional hypokinesia. But for the left side, echo is not necessarily the best in the way of screening, but definitely will be helpful in measuring progression of the disease. For the right side, it's a little bit different because there's more measurements we can take, and there's multiple different criteria that may include more echo images for assessing arrhythmogenic right-sided ventricular cardiomyopathy. So old criteria, or revised task force criteria, have some major and minor criteria that involve dimensions, which we'll talk about in a bit. But again, they include the presence of wall motion abnormalities with RV dilation or global RV systolic dysfunction. And in the minor criteria, they include aneurysm of the RV free wall as well. So as we go to the ASC echo guidelines for the assessment of the right heart in adults, I'll talk about some of the measurements and views that we obtain on the right side in the next couple of slides. And all of these kind of pictures and information comes from these guidelines by Rudsky back in 2010. So when we're imaging the RV, of course, first thing we usually look at is the parasternal long axis of the RV anterior wall. In this view, we can get a sense of a measurement of the RV. You can do an RVOT dimension by 2D. And in this view, we can also get a sense of if by visual estimation, the RVOT looks slightly dilated. So remember, in kind of broad sense, our rule of thirds, that the RVOT, the aorta, and the left atrium should all be roughly the same size. And if one of them is a little bit more elevated or bigger than the other, then potentially it's dilated. Then by fanning down, looking at the peristernal long axis of the RVOT and the PA, here we can get the anterior RVOT and its long axis. And as this is another view that we can measure the RVOT, we can measure the distal RVOT in here. So again, peristernal long, we can measure the proximal version of the RVOT. And looking at the PA, we can measure the distal version of the RVOT. And I'll talk a little bit more about that and those measurements in a minute. Then if we look at the RV inflow view, obviously this is important for interrogating the tricuspid valve, but we can also assess the inferior and the anterior wall of the RV from this view. Again, inferior wall of the RV being here, anterior wall being whatever we can capture up here. And then the peristernal short axis of the basal RV, again, we can see the RV anterior wall, we can see the RVOT both in proximal, and sometimes we can get a little bit of its distal segment here. We can see the pulmonary valve, tricuspid valve, usually the right atrium, and of course we can also interrogate the intraatrial septum. So again, in this view, we could measure the anterior RVOT for the diameter. So then looking at the peristernal short axis, this is probably our best spot to be able to measure the distal RVOT, measuring it there just proximal to the pulmonary valve. And then when we look at the peristernal short axis view, in the next image down below, we can't really get any measurements from this view, but we can get an overall sense of how dilated an RV is, what kind of the pressure and volume of the RV is. So again, remember, we're looking to see if there's any septal flattening that could be consistent with RV pressure volume overload. It's not really a good view for measuring function when you're in the short axis because there's asymmetric contraction of the RV. So you might not quite get a good sense of what the overall RV function is when looking at it in the short axis. And then going to the level of the papillary muscles, again, we can get a sense of some of the walls of the RV, the lateral walls up here, anterior wall here, inferior wall here. We can again look to see if there's any septal flattening that could be consistent with RV pressure volume overload. Then if we look into the apical four-chamber view, here we can get a sense of RV size, we can get a sense of right atrial size, we can get a better sense of RV function as well. So this is a good view for measuring all of the dimensions of the RV. So we can measure the basal dimension, measure 10 here, which I'll talk about a bit on the next slide, the mid dimension, and the RV length. So the basal diameter is generally defined as the maximal short axis dimension, is seen in the basal third of the right ventricle on the apical four-chamber. So again, somewhere in the bottom third of the ventricle on the four-chamber is where we would measure the basal RV diameter. The mid RV diameter we would measure somewhere in the mid 1/3, and then the length we take all the way from the apex down to kind of that line of the tricuspid annulus. And this is important for getting a sense of whether there is any dilation or not. And typically our reference values are a basal diameter of 42 millimeters at the base, 35 millimeters at the mid RV, which if greater than that can indicate some RV dilation. And in the longitudinal dimension, we're looking for something that's greater than 86 millimeters, which may suggest lengthening of the RV or RV enlargement as well. Remember, as the RV progressively enlarges, it will start to take over some of the apex as well, and so you'll get a longer linear dimension of the RV there. Now, some disadvantages to doing these measurements are the RV dimensions are highly dependent on probe rotation by the user, which can result in underestimation of the RV width. So if we look at this figure here, so 1 is typically what we're going for. So we want to try and cut the LV in the center plane and the RV where we get its largest basal diameter. But this is just to emphasize that we can cut the LV in several different ways, looking at 2 and 3 here, where the left ventricle looks exactly the same size, but we're significantly affecting the size of the RV. And we could significantly underestimate our RV sizes or dimensions here. And then other things we can do are looking at fractional area change. So fractional area change is basically an assessment of RV function that's measured in the apical four-chamber. It's the end diastolic area minus the end systolic area over the end diastolic area times 100. And it's a measure of RV systolic function that has actually been shown to correlate quite well with RV ejection fraction on MRI. And it's obtained by tracing out the endocardium in both systole and diastole from the tricuspid annulus all the way up to the apex, and then back along down the interventricular septum back to the tricuspid annulus. And typically they say the lower reference value for normal, according to the guidelines, is a function less than 35%. And then our last couple of views that focus on the RV. So of course we have our apical 5 chamber where we can still see the RV and we can see the moderator band. And then from that view, you can fan to actually get a sense of the coronary sinus view when you're in the apical chamber as well, to see the coronary sinus draining into the RA. And then lastly, our subcostal views. So again, our subcostal views are not really good for doing any measurements from the right-sided standpoint, but we can get a good view of the lateral wall of the RV up at the top of our image. This is helpful for looking at inversion of the RV or RA during things like cardiac tamponade if there's large pericardial effusions. And you can also do a short axis from the subcostal view where you can sometimes get some dimensions of the RVOT as well. And so I focused on this a little bit, talking about the RVOT through all of this, because it's important in some of the criteria for diagnosing the arrhythmogenic right ventricular cardiomyopathy. So here, again, just emphasizing you can get the proximal RVOT measurement in the peristernal long or short, and typically the distal measurement is measured best in the peristernal short, just proximal to the pulmonary artery. So according to the ASC guidelines for patients with right-sided heart disease, they should have measurements of the right ventricular basal, mid, and longitudinal measurements all on the apical 4 chamber. Again, visually, relative size of the right ventricle should be compared to that of the LV. And then the upper limits of normal for assessing for ARVC or dysplasia in the peristernal long axis, the proximal RVOT, the upper limit of normal is 33 millimeters. And in the peristernal short axis or the distal RVOT, the upper limit of normal is 27 millimeters. So just to show a couple pictures of what the RV looks like in patients with ARVC. This is one of the patients that we had through the Echo Lab a couple of years ago. And again, we can really highlight very dilated RV, some hypokinetic or akinetic walls, specifically, in the RV free wall and at the apex, significant areas of akinetic segments here. We see that the RV is very dilated. Often we get these increased trabeculations as well. That's not quite in any of the guidelines, but is a finding commonly seen in these ARVC patients, and quite a dilated ventricle. So just to go over some other data that has been done to see what might be suggestive in patients with ARVC. So we've talked a little bit about the RVOT measurement, and in this group of around 150 patients with ARVC versus controls, they do have significantly higher RVOT dimensions, so 34 versus 28 in the controls. RV area is significantly elevated at 23 in the ARVC patients compared to controls. So again, that can be measured. The area of the RV similar to what we do in measuring fractional area change. And then in the fractional area change as well, they have significantly reduced function compared to the controls. So in this data set, at least at around 38 versus that 46% in the control group. And so then to highlight some of the modified task force criteria for ARVC, so we touched on a little bit the newer criteria for diagnosing the arrhythmogenic cardiomyopathy that includes both the left-sided and right-sided disease. But this criteria was initially primarily for right-sided disease, and it had the RVOT measurements as major and minor echo criteria. So again, we see the same thing as we see in the 2020 guidelines. We're looking for RV, akinesia, dyskinesia, or an aneurysm plus one of, and instead of actually RV dilation or systolic function, they use RVOT dimensions. So a long axis RVOT of greater than 32 millimeters, so this would be the proximal segment, and the distal segment of greater than 36 millimeters, as well as fractional area change less than 33%, and some of the minor criteria where it's borderline but not quite as enlarged. And then to touch on strain really briefly, there's been some evidence and there's been some data suggestive of how strain could be used in these conditions. So some of the literature in RV at least suggests that RV strain has good diagnostic performance against kind of the reference standards from the revised task force criteria. So look at the akinesia, dyskinesia, looking at some of the dimensions. Reduced RV strain may help to identify patients with ARVC that don't meet task force criteria. Obviously, it's a little bit more difficult sometimes to get the full RV and a good view to do the strain images. And then from the standpoint of LV strain, it doesn't seem to add any diagnostic value for identifying patients with left-sided arrhythmogenic cardiomyopathies. but it does identify patients that might be high risk for deterioration. So it may be a good prognostic marker, but not necessarily a good diagnostic marker. The caveat here being that there's not good data yet for using strain imaging in patients with left-sided arrhythmogenic disease. And an interesting area that there seems to be some trials undergoing right now is if there's any evidence of reduced LV strain in the period of where these patients develop fibrosis, but they don't yet have LV systolic dysfunction or changes in their LV diameters or dimensions. So perhaps strain goes first in these patients, and we might be able to identify them. But again, that's common in a lot of other cardiomyopathies as well. So how specific it would be to arrhythmogenic disease is unknown. And then just to show a couple more clips here of quite dilated RVOTs. So these are some other patients that do have arrhythmogenic cardiomyopathy. And again, we can see that the RVOT is very, very dilated, maybe double the size of the aorta in the left atrium. Looking at the RVOT on the short axis, again, very, very dilated RVOT, and it corresponds with a very dilated right ventricle as well. So just because it's a relatively new entity, I'm going to go back to the Desmoplakin cardiomyopathy that we talked briefly about, that our patient had the genetic mutation for, and just discuss a little bit about the clinical presentation and some of the exercise guidelines associated with it. So this is a study published in Circulation in 2020 that investigated 107 patients with Desmoplakin mutation, and they compared them to the plakophilin 2 mutation, which is the mutation most common in ARVC. And this was just an attempt to try and better characterize patients with DSP. And so generally, the clinical presentation of these patients, it's generally higher prevalence in females. So ARVC was roughly 50-50. And in this population that had this genetic mutation, roughly 70% of them were female. Generally, the patients are a little bit younger. Their average age is in the mid-30s. Here it was kind of 36 plus or minus 16 years of age. In patients that have Desmoplakin mutation, the LV is predominantly affected, roughly 50% of the time. And this is in comparison to ARVC, where the LV is affected much less commonly. Patients tend to get episodic episodes. So similar to the presentation of this case, they have episodes of recurrent chest pain, typically associated with some troponin elevation, suggestive of underlying myocardial inflammation. They often get T-wave inversions, and if they have T-wave inversions, it's more common with left-sided disease than right-sided disease. And we do typically see late gadolinium enhancement or fibrosis on MRI in roughly 40% of cases. So the modified task force criteria, which is the ones I was just talking about with the RVOT dimension, is very insensitive for diagnosing the Desmoplakin or the left-sided version. As only 34% of patients tend to meet criteria for that. So the new criteria, the 2020 guidelines of the Padua criteria, are much better for that diagnosis. And the most sensitive signs are LV dysfunction, fibrosis on MRI, and frequent PVCs. So as I've said, again, just to kind of really reiterate the point, episodic myocardial inflammation is the hallmark of this disease. They get episodes of chest pain, usually with troponin elevations. Often they get false diagnosed as myocarditis because we see these non-specific patterns on the MRI, and they do have the elevations in troponin, which are less common with just general cardiomyopathies. If you do a PET scan when they're in a flare or when they have active inflammation, generally it will light up. But again, similar to what would happen with myocarditis as well. As we said, the inflammation or fibrosis may precede LV dysfunction. So as opposed to other cardiomyopathies, generally we may start with LV dysfunction and then get fibrosis. This might be the other way around. So in general, female sex is more common in DSP than in the plakophilin mutation. Moderate to intense exercise is reported in roughly 50% of patients. So 50% of patients that have these mutations generally do significant amounts of exercise. And it has been linked to disease expression, but not necessarily to disease progression. So in the ARVC literature, or the primary right-sided cardiomyopathies, there is good evidence that strenuous exercise may actually worsen or cause progression of the disease, but it seems to be less so, at least so far in the small sample sizes that we have for the Desmoplakin cardiomyopathy. Paradoxically, actually, moderate or vigorous exercise history was less commonly reported in those who had greater disease burden, in those that had the Desmoplakin mutation. So this is a study of assessment of exercise participation in adverse disease-specific events in another cohort of 100 individuals who had this mutation. They were followed over 5 years. They all had very significant exercise routines. They were classified as athletes or non-athletes based on having an equivalent of greater than 24 kind of metabolic equivalent hours per week. And they looked at patients that did more exercise and looked to see if they had greater ventricular arrhythmia-free survival or heart failure-free survival. So did they have increased arrhythmias or increased heart failure? And that was not true between the athletes and the non-athletes. They were relatively similar. However, interestingly, they did have increases in their myocardial injury. And we know that those that have increased myocardial injury go on to progress probably to have higher ventricular arrhythmias and higher heart failure. So it may just be that these patients weren't followed for a long enough period of time where they developed myocardial injury and subsequently had more arrhythmias. Really, we don't know the effect of exercise in this primarily left-sided or in the Desmoplakin variant. And so the guidelines so far, in 2019, initially the Heart Rhythm Society consensus statement recommended counseling those that competitive or frequently high intensity exercise is associated with increased risk of developing ARVC and ventricular arrhythmias. So they recommended against high intensity exercise. The 2020 European Society of Cardiology guidelines again recommended not to participate in any high intensity recreational exercise. And this is for any arrhythmogenic cardiomyopathy. So DSP just being one of them. But similar recommendations for ARVC. And in 2024, the Heart Rhythm Society released a statement suggesting that DSP may be a higher risk genotype and indicate that vigorous exercise may be associated with arrhythmias. So we are probably headed in the direction that exercise is not good for this mutation as well. The data is just not quite kept up or not quite there yet. And for ARVC, again, we know that the recommendations, this is from the ESC guidelines, but it's a class 2A recommendation that they can participate in 150 minutes of low intensity exercise. So it's still okay for them to do a little bit, things like walking, stuff like that's okay, but any moderate to high intensity is not recommended. But again, we can see that all of this evidence is relatively low quality, 2B, 3, class 3 indications. So there's really not enough data here to really say, but of course, if there's a suggestion that it may cause increased mortality, we want to do our best to try and prevent it. And obviously, there's a class 1 indication for following those on a regular basis, especially if they exercise. And looking at Desmoplakin specifically, it's a class 2A to consider maybe following them a little bit more frequently. So every 6 months instead of every year that you might do in some of the individuals. So just to pop back to our case briefly, just to kind of close the loop here. So based on her genetic profile, she was deemed to have relatively high incidence of sudden cardiac death, roughly 3 to 5%. So she went on to have an ICD, which she just had a couple weeks ago, and was referred to Advanced Heart Failure and Transplant Program at TGH just to kind of continue to monitor her over the coming years. So in summary, we talked about a 34-year-old female who had recurrent episodic chest pain associated with elevations in her troponin, with a borderline reduced LV function and frequent PACs, with a cardiac MRI demonstrated biventricular late gadolinium enhancement, and genetic testing was positive for Desmoplakin. Our learning points here: trust your gut when something doesn't add up. So in this patient, she was having recurrent flares. You don't usually have recurrent flares of myocarditis. Like usually it's triggered by some sort of viral infection or something. And the fact that someone was having continuous episodes with recurrent flares seemed a little bit unusual. Hence the workup for sarcoid, which still turned up unusual. But that goes into my next point, that maybe early adoption of genetic testing will help us to gain some diagnostic clarity. You know, now compared to 2 years ago, compared to 5 years ago, it's so much easier to get genetic testing, and the panel has expanded so much from 10 genes to 30 plus genes that we test for. So definitely it's a lot easier, and early adoption of genetic testing may help to gain some diagnostic clarity. And then there's new classifications of arrhythmogenic cardiomyopathies that are much better to look at both the left and right-sided disease. There's new criteria to assess for both. And then our echo learning points. So from the standpoint of the LV, reduction in GLS may be helpful, but more studies are necessary. Obviously, we know how to look for LV dysfunction and LV dilation, and those are usually more late presenting features of this disease. And then careful acquisition of the RV in the correct plane is important to ensure accurate measurements, because again, small movements or directions can affect the size. And maybe we could consider adopting measurements of the RVOT when we are asked to assess patients that have RV dysfunction or right-sided disease, specifically ARVC. So again, just to highlight, we talked about this case of recurrent myocarditis. We discussed some etiologies of ARVC, reviewed echo imagings of the right ventricle, talked about features of Desmoplakin cardiomyopathy and exercise restrictions and their guidelines in ARVC. And that's all. Thank you.